the thing I was really grateful for was when I was working with HPG and particularly the consultants is that they looked at me as a whole person and they were like, wow, this is amazing. Like, you've got all these different amazing skills. I'm going to put forward this really left of field job that you've probably never even thought of, but it's combining all these interest areas that you have, which I really appreciated.
Welcome back to another episode of HPG Engage, the podcast. I have the pleasure of sitting with Zoe Callister-Hakewill today. How are you?
I'm good. I'm happy to be here. Thank you.
Zoe is a general manager for Doctors on Call. She'll give you a little bit of a background on what that is and who they are. She's also the editor, Australian editor, for the Innovation and Impact Scientific Technology Business Journal.
Yes.
A mouthful.
Yes.
And she also, on our podcast, but she's also a podcast producer and host at Beyond the Medicine Cabinet podcast. That's absolutely the one. But firstly, before we start in, I like to just, if people have any kind of social media platforms that they use for for example, your podcast or for your editing, I like to give people the opportunity to kind of just tell them where they can find that before we go into the main conversation.
Yeah, so most of my social media stuff I do on my LinkedIn.
Okay.
That's my area. But otherwise, you can find the podcast on Listener and find it anywhere you get your podcasts, Apple, Amazon,
Spotify.
All the places.
But go to Listener to listen to it, though.
Yes, because it is a listener podcast.
It is a listener podcast. Just plug that for you there.
Yeah.
Awesome. So one of the main reasons why we wanted to talk to you is, one, you've been going through the recruitment process here at HPG, but also your resume is very interesting. Your education is one that's very interesting. You've done quite a bit. And also your experience within the healthcare space, again, very, very interesting. So Zoe's going to give us a bit of detail into all of that. But you started off at university studying a Bachelor of Medical Science.
Yes.
Why was that?
Well,
what was the idea behind that?
I think I really wanted to actually do medicine and wanted to become a doctor. So I thought, Bachelor of Medical Science, Sydney University, that'll set me up really well. I'll be able to go straight into postgrad med, no worries. And I think the reason why I wanted to do medicine was because my family's medical, so we've been in medicine for, ages.
Yeah.
So very much a part of growing up and that idea of altruism and serving other people and very much ingrained in my DNA, I suppose, and giving back. Spent a lot of time amongst vulnerable communities and just thought, definitely that's where I want to go. And I also think it's a bit of in school, there's very much distinct pathways. It's either you're going to be a lawyer, you're going to go do business, or you're going to go be a doctor, basically. And so for me, that was medicine. And from there, I decided that I would study a Masters of International Public Health because I realized that there was a lot that I didn't really know about the world and the health issues that are so relevant to us. And I went overseas for a little bit, spent some time in South Africa, and I think that really did open my eyes as well, that experience. So really loved and enjoyed that. Thought that would really put me in good stead to go do medicine. Kept studying for the GAMSAT, kept trying. Didn't quite make it yet. So then I was like, okay, well, there's all these vulnerable communities. I may as well get some knowledge on how to look at that from a legal perspective. So I went and did a Masters of Health Law at UCID again. Back to UCID.
I'm back.
I'm back. Hi. And thought that the legal framework would be a really interesting way to really frame, the responsibilities of health professionals and the rights of patients in that space and allied health professionals as well. And then I also became really interested in neuroscience as well and decided whilst I was, I kind of did some time in a law firm in personal injury, but then decided, wasn't for me.
Yeah.
So I was like, okay, I'm really interested in neuroscience. How about I go do some psychology? So I went to Macquarie University this time and started my Bachelor of Psych honours, enrolled. But I didn't graduate with a Bachelor of Psych honours. I graduated with a Bachelor of Science Psychology because I didn't do my honours year in the end.
Got you.
So that's kind of how that happened. But yeah, so loved it, became super involved with the cognitive science department, went and looked at brain health in high contact sports players. So looking at, concussion and how that happens. And then we had this opportunity from Emotive, who actually has their building on the Macquarie University campus, to validate a new product called an EEG emotive device, where you put it sort of on someone's head, and it's got all these little electrodes that you can measure their brain activity. So we did a whole, scientific exploration around this. So I was sitting on the sidelines, pulling off AFL players.
Yeah, I was going to ask you, would it have been AFL players you'd have been dealing with? Because the whole concussion, is it CTE?
Yeah.
Yeah, that's quite massive in the United States, obviously within American football, because a lot of their tackling is done with their heads in helmets. So, and obviously in the States, much like here, whenever kids choose a sport, they're playing it from they're 6 years old.
Yeah.
So it's just, and even at 6, they're running to each other's heads, or running to each other with their heads. So the whole concussion thing is definitely something that's been brought to light probably over the past, say, 50 years, because no one really understood why players after they retire go a little bit crazy, and they become physically abusive towards their partners and their children, and they couldn't understand because they weren't like that while they were playing. So why now that they've retired, they've kind of lost it. And then through the research, just started to realize that it's been the 20 to 30 years of playing a sport that's kind of messed up their brain a little bit.
Absolutely. And I think there's so much we still don't know in this area of research as well. So it's really exciting to be doing something practical, because like you mentioned, I remember going to a seminar or a conference, I think it was, with the brain bank that had just been sort of linked with the CTE, and they decided a whole bunch of high profile players were going to donate their brains to the brain bank. And this,
after they passed?
Yeah, after they passed. And so we heard some ex-players speak on this panel, and some of the doctors that had treated them. And it was really sad, because they were recounting stories of, how they felt at the top of their game, and they were really active and cognitively with it for their whole lives. And then they get to this point where they start to develop memory issues, and aggressive behaviours start to come out, which, if you ask their spouses, it's something that was never
a thing.
Yeah, really, in their relationship. And it's really, from the spouse perspective, it's really sad to watch a loved one transform in front of their eyes. But particularly this one story of a player who had lived in his house for 20 years. And he described one day standing in the bathroom and not remembering how to open the door, or which way the handle, or just being really confused, and having these moments of lucidity, and then going back into, brain fog. It's really scary for these people. Yeah. And I feel like, there's not a lot of culture in the sport to sort of go off and sort of take a break if you have had some sort of head injury or head collision. You may not necessarily know if it's a concussion when you get, briefly pulled off the field. I think there definitely needs to be a cultural shift to support that, to say it's okay, like you can take a break for the rest of the game, because it's for your long-term health, particularly your mental health, much better decision in most instances. Yeah,
for sure.
And the thing that you brought up about small kids, that was something that really resonated with me a lot, because I was noticing that these young kids, as young as 4 or 5 years of age, are going to play, and having these injuries. I think there's certain rules now, even in soccer, we're not allowed to headbutt the ball from a certain age, but still, accidents do happen where they can sustain an injury. And for kids, that's like a whole other level of issues from a young age. It's like you're going into school, and you may be sitting there and not able to concentrate because you've got that brain fog from, you know, a concussion that you didn't realize that you had on the weekend. And also the really hard thing about concussion is that you don't know, there's no criteria that's solid enough for you to say, yes, definitely. Yeah. You can have a head knock as well and still experience those symptoms. And that can transform into difficulty in learning. That's just something that I really loved and was so passionate about. And for the first time, realized that research could be super impactful and super meaningful and hands-on. And so we were using this amazing device to test players and their brain health, and then comparing it to the gold standard EEG that you would have in a lab, which costs about, you know, $90,000. Jeez. This was amazing because this device costs $1,500. So we were saying, I guess the whole thing behind it was if you could use this device to make any informed choices around potentially diagnosing concussion, and it was accessible financially, it could really change the sport and could really change the experiences of the players in the sport. So through that, I think I became quite an avid, not proponent, what's the word when you, advocate. So one day I actually went up to Peter Fitzsimons in a cafe at Mossman because I knew that he sat there and wrote his book. And I just started chatting to him and I was like, this is really cool. This is what we're doing at Macquarie. You know, it would be really great if you could put an article in your column. So he did. He wrote an article. Yep. And he was happy to do that. And then through that, we got some coverage with the Channel 7 News. And I even reached out to the ABC and was able to secure a slot on the ABC to, talk about the research we were doing. All from this perspective that if you can get more exposure to the problem, particularly in research, you can get more funding, get more government grants, and then you can do more, which I think is really important. So everyone would always joke that I was like the salesperson on the research team.
Sometimes you need that.
Yeah, and I think particularly for researchers as well, because they're so amazing and they've got these amazing brains, but sometimes I think they get a little bit shy or maybe unsure of sort of putting it out there in a way that is commercial for them to then beneficially get more support. So I took that on as like a little challenge, and I was like,
side hustle.
I'm going to help this happen, and I'm going to tell the story and help this a little bit. So so I loved that. Found my way into doing Doctors on Call. And decided, again, education-wise, because of all the things I had to do with that, I probably should go do an MBA because I had no formal business training or understanding of some of the processes that I had to implement. So that's my really long explanation of my background and education.
I love it. I'm here for it. So you just mentioned Doctors on Call there, which you currently work for, and you've been with them since 2015. But just to start off, can you explain exactly what Doctors on Call is?
Cool. So Doctors on Call is a really amazing initiative. It's basically the mission is to provide healthcare to people in their homes. So if that means bringing in pathology or mobile x-rays or doctors or allied health professionals, it's all about bringing it all to the patient. And that can be through virtual care, or it can be physically, where we send doctors in to treat patients. And generally we focus on those who are either cognitively
less able-bodied to move around as freely as from a day-to-day aspect.
Absolutely. That's it. So we try and we've done a little bit of work with the Cerebral Palsy Alliance. We've done a little bit of work mostly in actually aged care. We've done a little bit of work with Housing Commission Australia, Mission Australia in Housing Commission, to make sure that everyone tries to have access to our services. So our clinical team is amazing, and they work tirelessly, and they worked tirelessly all throughout COVID to make sure that this has happened. But it's a big job. It's a really big thing, and particularly in the current, background of crisis of COVID, it's not easy.
Is it all over Australia at the moment, or is it mainly New South Wales?
We've been asked to go into other states.
Other states, okay.
But we just have to work out. That's a whole other logistic, thing that has to happen. But we don't really have any plans for that anytime soon.
You probably got to make it almost perfect tier before you can then almost expand, I guess.
Yeah,
you got to master it. Yeah,
that's it. And you don't want to be sort of overstretching yourself and providing subpar care to someone.
100%, I agree with that.
Because you want volume, you know. I think that's sometimes where people can fall down, or businesses can sort of come apart in healthcare.
Yeah,
they scale too quickly. Yeah. So we've been really mindful of that, and we've been really careful with the way that we've built it. Even when I first sort of came into my full-time role, because I wasn't full-time in 2015, I was working part-time, just sort of doing admin and outreach and support and all that sort of stuff, and just, you know, some financial billing, and then I came full-time in 2020. It looked like such a different business back then from before. So a lot of my role has been making it more accessible, more efficient, you know, particularly digitally, because we've got this whole other arm of telehealth, which weirdly enough has sort of existed for, you know, 30, 20 years.
Yeah, never really used.
Yeah. And I definitely think with the introduction of the MBS items supporting this, I think it's definitely made it more accessible to so many more people, which is amazing, particularly in regional remote areas.
Yeah.
And there are some really awesome companies who are doing some spectacular work in this area to help provide care. You know, I did a podcast episode on Vision Flex. Mike Carmen's very passionate. They reach into Indigenous communities. They're in Antarctica helping, you know, film surgeries for people in, you know, the cities to instruct local doctors to help treat people.
That's
and
amazing.
The prison system as well. That was so fascinating to me that he was, you know, really in this area of treating inmates, and then Sylvia Pfeiffer from Cove U, she's, you know, doing an incredible job. Very much started out from, I think originally they were doing speech pathology and wanted a platform specific for speech pathologists in regional areas, and then it just kind of grew into this amazing platform that all health professionals could use. So I don't really know what my original point was, because I get very passionate about startups and tech innovation.
You were just pretty much saying all the different telehealth options that are out there, and that are now being implemented across the healthcare space. But I wanted to touch on the Docs and Call. You said that your role when you first started part-time ended up very different to whenever you went full-time in 2020.
Yeah.
So just to start off, what exactly was your role part-time when you first started, and what was kind of the reason why you decided to go and work with Doctors and Call?
So my role beforehand was sort of more outreach manager, so just anything admin, anything sort of, I don't know, talking to, if I had to go talk to a facility, I'd go talk to them. Kind of
the
very
liaison kind of thing,
whatever. You know,
bits and bobs,
like, you know, it was just like a little bit of a side thing that I did to help out. And then 2020, couldn't do any more research, kind of also needed some money to, you know, survive, but also realized super passionate about the elderly and vulnerable people, and it kind of feeds back into my whole love of neuro and you know, you've got Alzheimer's and cognitive impairment and all these other different things that I think get a little bit sort of ignored. So I thought this is amazing. They're trying to, you know, create practical solutions, but I can see we can do this so much better. That was a struggle, doing a whole different patient management system.
Oh, would be.
I went through a really long phase of talking to so many different companies about their software solutions, because a lot of them are built for like either general practice where the patient traditionally comes in and and the doctor sits there typing while you're talking. Or they're built for a specialist, for example, in cosmetics. You know, where it's kind of a little bit, the functionality is a bit different, and you can integrate different features depending on what specialty that you're using. So for us, it was really important to us that it was mobile. So we couldn't, you know, for example, something simple as having a server that was cloud-based was really important to us. We also needed to have the ability to bill from that platform. We had to have the ability to do e-prescription so that it was more efficient for pharmacies to receive medications for patients, so they didn't have a period of time where they were waiting for pain relief, because that's another big part of aged care, and particularly when you're dealing with vulnerable groups, a lot of them have chronic pain, and you're inherently dealing with complex diseases all at the same time. So a lot of my role was actually going into the pharmacies, chatting with the pharmacists, going, hey, what's your workflow look like? How can we increase our efficiency? How can we make sure that your program plugs into our program? And then the medications go off so that the patients aren't waiting. So that was another consideration. Another consideration we'd have was the type of note-taking in the actual program itself. Some of them had timers on them. Some of them had non-compatibility with Windows or Apple. So, and I think eventually we went with, after speaking to so many different companies, eventually we did go with MediRecords. Even though it wasn't distinctly made for us, we were able to have workarounds. Like, for example, the appointment book, it's assigned to individual patient profiles inside the patient management system. We just allocated our facilities or our locations to be patients so that we could book them in for a telehealth schedule. So a doctor could look at it and go, oh, okay, I've got my next person here at this location. So it wasn't perfect, but it was the best we could do.
Yeah, it did the job for what you needed it for.
Exactly. And I love MediRecords because I feel like their team's super responsive to us. It's cloud-based. They've always been working with us, with feedback on, how it's working in our practice. So, it was good. And then the next step after that was building out governance and policy around the way that this would be used, because it's a new technology. Training as well, training our clinicians on how this would be used in situ, which again was another challenge point, because you're trying to talk to these amazing people who've studied for like 30 years.
And you're trying to teach them something new.
Yeah. And there's processes that are very linear, in place for a really good reason, particularly in aged care, because people die all the time and you don't want it to be a mistake, So you've got to make sure that you're sensitive to their expertise, but also like you're trying to teach them something new to help them.
Yeah.
And so there's always that initial, push back, and you've got to find a way to make it work and be respectful of their expertise. So through that also we had challenge points even implementing telehealth. So we had to find a good telehealth platform that would integrate with our MediRecord system after that. So we chose to go with CoView. And then that was amazing because, again, double encryption, super secure, no one could drop into the consultation. It's so important to have that confidentiality. And whilst we were doing this also, because it was so new, there weren't a lot of guidelines around what we were implementing. So they hadn't quite finished writing the telehealth guidelines. They'd sort of said, okay, you can do telehealth and here's some billing items, but they hadn't actually finished writing the regulations around what that could look like.
How was kind of navigating and creating all these new processes for doctors on call during COVID, during the whole pandemic? Because obviously that already sounds difficult enough as it is, trying to implement all these new processes within an organization like Doctors on Call, taking away the paper, the fax, going to email, the tablets, going to telehealth, implementing new software across the business. But then adding the fact that you probably weren't able to even travel that far outside of your suburb or even meet people in person. How was that for you, I guess, navigating all of that? Yeah,
it was really tiring, not going to lie. I worked quite a lot, probably 7 days, probably barely slept, to be honest. And then sometimes even if I would go to bed, anxiety around just...
You're like, oh, I've got so much to do
Exactly,
tomorrow.
And just wondering, did I say the right thing or did I write the right thing down? And I was getting asked really quick, tricky questions as well. All of a sudden I became this governance person. And I got, even not just from my own team, but also from the people we were working with in aged care, ringing me up going, hey, we've got someone who's just died of COVID. How do we dispose of the body? Yeah. So then that would be like, okay, let me just get back to you. I don't know. I'll find out the answer for you. So again, a lot of the documentation was still being written by the government at the time. We were getting updates from the government and on the websites and stuff. But there were all these different regulatory bodies that were coming into the aged care space in particular, saying that this aged care facility has to do it in this way. And so it was very stressful also for our stakeholders, I suppose, and the people that we were treating and the staff we had to work with, because they were getting told all this conflicting information and things that weren't logical, like even where they should position their residents within their building. Some of those generalized recommendations didn't really make sense. So some would say, oh, yeah, you've got to put them upstairs if they've got COVID. And then it's like, well, from a fire safety perspective, like there's nowhere to exit out of the building like safely. Like, do we leave everyone inside if they're sick? Like, so there were all these interesting health ethical problems coming up in my day-to-day, which was useful because I definitely used my public health and health law training.
Yeah, Shannon, yes.
But also crazy at the same time, because we'd go through these little scenarios in health law about, who ges the hospital bed. Is it the young person or is it the old person?
Yeah. What is the answer?
Well, during COVID, it was interesting because a lot of our hospitals were unfortunately over capacity, and so they were sending back our elderly patients.
Okay.
And that put pressure on the aged care facilities to then become a hospital in the home kind of situation. But then again, that they don't have capacities like an IV, for example, to put in an elderly person, because there's a certain level of qualification you need for a certain person to go in, and a nurse that's qualified to do that. Or, even where the oxygen tanks were stored, if someone needed oxygen, and you couldn't use nebulizers because airborne particles could help, spread COVID in a communal environment. So it became really challenging to navigate that. So we tried the best we could. I had a lot of meetings with our aged care facilities in particular, going through information that I'd found out or researched, answering questions as best as I could, talking to public health, talking to the local health network teams like the GRACE team, which is sort of like the hospital outreach service in the eastern suburbs. And we also have a similar one in the North Shore, mostly. And then we also ended up getting a lot of conflicting information. And then this punitive system also was established in aged care, which is like a SEERS reporting system. So instead of opening up a forum to discuss, mistakes or something they do differently, it was this whole investigation that was opened up on individual people in aged care facilities going, oh, they did this wrong. And so people were reluctant to report if something went wrong So a lot of what I ended up doing was writing documents to help them check off certain requirements that the AGS&C, qualitative people for aged care that sort of help say, sorry,
we've done this, we've done that.
Yeah, exactly. So they could come in and do a surprise inspection and look through everything and either say that they've passed or they've failed. And so I was writing these shortcut documents for them to tick off things because the nursing staff was so stressed and overstretched.
Definitely would have built a level of comfortability for them knowing that, okay, if we do this, then we should be fine. Yeah. So that's kind of the perspective that we took. We tried to be supportive, and I think through implementing and working with our stakeholders, that sort of spread around. And so in addition to sort of physically going out to aged care facilities or just, different locations, say, hey, we're here, we can help you. We got a lot of referrals internally too, to say these guys are great. They support us, we trust them. We did a lot of education and training. We ran sort of sessions around even vaccination delivery. A lot of people were unsure about what that looked like in aged care because we were the first cab off the rank. We did a lot of infection control, I suppose, training as well for the nurses donning and doffing. A lot of the nursing staff also unfortunately left as well because it was very stressful from a mental point of view. So I tried to also work with some of the facility managers on how to better improve their mental health, and gave them, research and tried to provide, documentation on practical tips and all that sort of stuff, and just even being there and listening to them about, some of the struggles that they were going through or with work. Through that, I think we built a lot of rapport and established a lot of trust, which I'm really proud of in aged care. Particularly being a young person coming into aged care, I think it's really easy to go, oh, boring, don't want to do that. But you don't realize how much there is in there that needs, or not needs, but could be done a little bit differently to help it be done more efficiently. Exactly.
Yeah.
That's amazing. I think this is one of the reasons why we do this podcast, is because we like to speak to people who have done different things and amazing things within healthcare, and especially when they've done and gone off the beaten track. Like, you have your degrees, your masters, but you probably, when you're doing this, you never thought, I'm going to end up in Doctors on Call as your general manager in the middle of a pandemic, trying to create new processes, trying to improve aged care facilities across New South Wales's experiences and the, I guess, the elderly that live there, trying to improve their lives. Like, that probably was never the thought process.
No.
But just through your willingness to learn, your willingness to see the world, your willingness to, I guess, help people who are underprivileged, it's kind of serendipitous that it's fallen on your lap, and you have obviously done an amazing job in improving the lives of many people across New South Wales. So I love that. I love that.
Thank you. That's
No,
really
you're welcome.
nice. That's really sweet.
No, but
at the
it's
time,
amazing.
It kind of doesn't really. You're not really thinking about
Yeah,
it.
you
Like
don't
that,
don't think it because you're just on the ball trying to
Yeah.
get things done. But when you do take a step back, it's like, when I've finished, you're in your head, you're probably thinking, when I finished high school, this, like, I've never expected this.
Nah.
I was expecting to be on a hospital floor in A&E.
Yeah.
But now you're here, and I can tell by the way you speak, you look so passionate about it, which is amazing.
Yeah.
Which is what we need within the healthcare space. We need people who are passionate about helping people. So, moving on from Doctors on Call, we've touched on this a couple of times about the commercial aspect of healthcare, and understanding that as much as we are in this industry to help patients, there is a level of commercializing and sales that goes into ensuring that we are actually able to provide the best service, because you need money a lot of the times for things to get done.
Yes, you do.
So can you give me a bit of an insight into what you think about that part? Where do you think, I guess, a lot of healthcare businesses and companies may potentially be falling short in that realm?
Yeah. Well, I don't know if I'm the expert on where they're falling short.
Just give me what you think. Tell me what you think.
I'm still learning. I love learning, as you know. But I think it sort of crossed my... Again, it's this idea that I'm a big believer, like, you can work really hard, yes, but also luck comes into it, and you kind of get just plopped into wherever you end up being.
Mm-hmm.
And so this was kind of another one of those moments where I was fortunate enough to connect with Rabab Nasrallah at Incubate at UCID through my brother, actually, who he works sort of in the entrepreneurial space, because of my research in concussion, because he was telling me that her sister works in concussion, and she's incredible.
Okay.
She's this amazing researcher. She works at Queensland University in the Brain Institute, part of that, and looks at biomarkers of concussion right now. So she's doing an amazing job, but connected with her, and basically she started telling me about this whole world where after I'd spoken to her what I'd done, to try and get more money, she was like, that's amazing, because we've got this massive gap, particularly in Australia. And it's the chasm of death, where you're trying to get your research over this chasm into a commercial product that people can practically use and embrace in their day-to-day lives. And that's a really hard thing to do. And I don't think sometimes, again, this idea that researchers are amazing with coming up with these incredible innovations, but I don't know if there's infrastructure in Australia, and there kind of is, and it's getting better, but it's really hard to jump over that gap to get the funding that is needed. So yeah, she said, I'm doing this journal. Do you want to be part of the journal to really highlight this problem and look at all the startups in the Australian ecosystem that have either jumped over that gap and successfully secured funding and have made it to market both here and in the US. And I said, would love to. So I came on as a writer at first, and I got to interview and write about this amazing company called Detected X, who was looking at training radiologists in identifying breast cancer, because they were finding that they were getting a lot of misdiagnoses or missing things, and there was a gap in the training tool. So that was incredible. And then since COVID, they've actually branched out into other respiratory illnesses like COVID.
Oh, that's good.
Yeah, they've done an awesome job. So yeah, I loved that. And then she said, okay, do you want to work with Fatima Nasrallah, who is her sister and is the one working on concussion? and edit with her on the next edition. So I was like, okay, yeah, I'd love to. So basically my job became finding really cool companies in Australia, reaching out, connecting, convincing them that would be a cool idea to come into our journal. We had a little checklist that we made of certain criteria of what we wanted in the journal, and 4 of us signed off on it. So we also work with an international journal team based out of Europe and the UK, because it's part of a Cambridge-Oxford University initiative to highlight this problem over there as well. So, does that seem to be kind of a problem in the UK and Europe as well? Less of a problem than it is here.
I feel like the US is probably the best place. They probably have the commercialising thing down to a T.
They do, but I think it's very much because their health system is a bit different in the sense that it's a user pay system. Yeah. So patients expect to pay for their medical treatments. Whereas here, it's amazing. We're so lucky that we have Medicare and we've got subsidies from the government to pay for our medications and treatments. But I think that the mentality that results from that, from a patient consumer perspective, is that they feel like they don't need to pay for medical technology or treatments. So it's a whole different market over in the US. And if you make it in the US market, you've basically made it, as an innovator.
Yeah, for sure.
Your goal is Silicon Valley. You want to be there, and you want to, that's how you've succeeded. And we've got some really cool examples of that. Like Canva is always held up as like the gold standard example. But so in Australia, we were looking at the ecosystem here. Then decided on 12 sort of companies. Then I had to recruit 12 writers, train them on how we wanted the article to be written. They wrote the article, interviewed the company. It was a bit of back and forth, and then I edited it with Fatima, and then we sort of sent it off to our international journal team to pull it all together on the website. So that's like pretty much what's involved, but it's quite time consuming.
I can only imagine. Writing is just it's a long process. Yeah,
but with that I was very lucky because I got to connect with a lot of cool people in the ecosystem, and even some of the people I didn't put in the journal ended up being amazing later for when I got approached to do the podcast. So I could use them for the podcast instead. So that was good.
I love that. Speaking of, I guess, building relationships in healthcare, you've been going through, I guess, the recruitment process here with us at HPG. Luckily, and you've worked with a couple of our consultants while you've been doing that. How has the experience been for you? Because your resume is it's not siloed in one direction. It's kind of touches in different spots. So how has been the experience for you at HPG, and I guess going through that process in terms of finding potential roles that you might be interested in?
No, that's a really good question, because HPG is very much different, I've noticed. I've spoken to a lot of recruiters, particularly over the phone, and they don't really know what to do with me.
I remember you saying this in the Zoom call. I was just like, that's so funny.
They're kind of like, you're kind of all over the place. I was like, I know.
That's me.
Yeah, sorry about that. I think for me, I've never really committed, I suppose, to the traditional linear trajectory that is expected in healthcare. And funnily enough, I think in Australia in general, people just want to fill boxes. The thing I was really grateful for was when I was working with HPG, and particularly the consultants, is that they looked at me as a whole person, and they were like, wow, this is amazing. Like, you've got all these different amazing skills. I'm going to put forward this really left of field job that you've probably never even thought of, but it's combining all these interest areas that you have, which I really appreciated, because it would never have been a role that I would have thought of in a million years. But then the more I think about it, the more I think that's actually perfect for me. And it's something that I think I could really see myself doing, particularly bringing in a little bit of, I think being in Doctors on Call has set me up really well, because I was able to sort of jump into a whole variety of different roles. And so it gives me this this understanding of the way that a business works. But I think I'm really hungry to sort of get into another business now and see the way that they operate too, and learn more about that. And I'm really keen to get, mentored at a maybe even a large organization that's, doing something that's also positive for patients and empowering patients. And that's also going back to my passion with the podcast as well. The whole reason why I started it is I realized when I was delivering education and training, that people were finding health information in the weirdest of places, and it was getting very inaccurate. Like I had questions like, I don't want to put fetus in my body as part of a vaccine, which I can understand how they got there, because you can use stem cells, embryonic stem cells, to grow certain medications. But it's just this awareness, this
that must
realization.
have been a rabbit hole to get to that point.
Yeah.
That wasn't me the first response on Google.
Yeah.
That's 7 pages deep.
Yeah. That really is. I'm sitting up late at night, like trying to scroll through there.
Oh my goodness.
Yeah. So I just became really passionate about empowering patients and people around making better choices around their health. And luckily enough, I've been put forward for roles that are very much about that and very much aligns with my values. And my passion area of empowering people to make their own decisions. Because at the end of the day, I think we're becoming a more patient-centered healthcare environment anyway.
Yes, that's true.
We're moving away from that traditional fiduciary relationship between the doctor and the patient, where the patient...
It's just like another number kind of thing. It's a little bit more personalised now.
Yeah.
And it needs to be.
Yeah, and patients are asking more questions of doctors, which I think is amazing. And doctors are also finding themselves providing virtual care, which is requiring more of them anyway, in a more individual approach and delivering medical solutions. So it's amazing. Very lucky. But yeah, back to HPG. I think what I really appreciated is that I was seen as the whole person. I think a lot of the time I go, oh, here's everything of me. Like, what can you do with it?
Yeah.
Whereas other recruiters were kind of like, you're not...
We haven't got anything right now
exactly
that we can put you in.
Yeah, because they're looking for a very specific linear person.
Yeah.
One of the feedback I got was like, I lack focus, which is interesting because, not from you guys, but from another recruiter, which is interesting because there's not really much I can do about that. Yeah. Because I feel
do you though? Because I mean, based on your time at Doctors on Call throughout the pandemic, I feel like a lot of focus was definitely need to do all that.
Thinking. Yeah, 100%. So weird, and I feel like you need a lot of focus to sit down and study for hours on end.
Oh, for sure. I'm like, you've got a few degrees there. I struggled for my first bachelor just to focus, so I can't imagine everything post that. So interesting. But I think that's such a good point that you've made about our consultants when it came to them looking for a role for you, because I think one thing we do here at HPG, because we are purely specialised in healthcare, like you said, we look at the whole picture of the candidate that comes to us. We don't see your experience as general manager of Doctors on Call and think, oh, where can we put her? Yeah. But then we're like, okay, well, she's been an editor for a journal, she's been doing some Doctors on Call. Then obviously they do the call with you on Zoom and get way more information. They're like, okay, she's actually done way more than her resume does say. Let's try and go a little bit left field here and just see what you think about this. Yeah. And then, like every other experience you've had so far, it wasn't really planned. It wasn't kind of at the forefront of your mind, like, oh, I'm going to do Docs on Call, I'm going to be an editor for a journal, I'm going to start a podcast. That was never kind of the thought process. It kind of just happened, and it came through the way you built your relationships, through the experiences you've had, and through, I guess, all the degrees that you've studied. Yeah. So again, a lot of the times that's how life works, isn't it? You kind of, things just fall on your feet, and you kind of just assess it whether it's the best thing for you, and you go with it and see what happens. Yeah, no,
absolutely. And I think also, you can never really plan out what you're going to do. Like you mentioned before, if you were to think about it leaving school, I never would have put myself in this position. I never would have thought, like listeners getting...
Same with me, just even living in Australia.
Random.
Just very random.
Yeah, random stuff. And you look back at the time, and it can be frustrating when you're going through it, because I'm the type of person that's a bit type A and needs, like, I need to know my next steps. Yeah. But for the first time, I think I've sort of let go of that and gone, okay, I'm just going to be open, see what comes my way, hoping that someone will see something that they can, find valuable for me to be involved in. And I've got a lot of value to bring, and I think particularly in that commercial space, I'm really interested to get more into that, because I think there's this hesitancy to be commercially minded in healthcare. But you need to be, because a lot of the time, unless the research gets the funding, you're not going to make it to the shelves. You're not going to ultimately impact people's lives and change the way that patients are treated or seen in healthcare. So part of me, I think, for the podcast, for example, it was like, okay, I have this amazing drive to want to change the way that people tell stories around technology, because we're not looking at the patients, we're not looking at how doctors are implementing it in their practice, but how can I do that? Okay, I need some funding.
Yeah.
So I'm going to go out and I'm going to pitch this idea to all these different organizations and see whose values align with mine and who can see things the way that I see it. And a lot of the time when you put yourself out there, you find that people do genuinely want to help you.
Exactly.
Which is amazing. But also you need to have those statistics. Like you need to, know your stuff. Which I didn't, by the way. Like I had no example of like how it's going to turn out. It was just lucky it turned out the way that it did. But yeah, I was really lucky because I had an organization who believed in me and believed in what I could do. And I'm also a big believer of picking up the phone, or I'm a big believer of like putting myself in front of someone, because I think when you put a resume in front of someone, it's really hard in 2 pages to explain your whole personality and explain, the way that you do things, the way that you go about things. And I think I appreciate that about HPG. I was like horrified to learn that people use AI. I mean, I love AI, but I was horrified to learn that that's what they use to go through people's CVs to place people for a job.
That's the thing. Yeah, it's a lot more used in larger companies and larger recruitment companies, because they probably just get thousands a day. Yeah. So they pretty much use AI as a means of picking out keywords. So I think you have to be maybe 75% match with the job description in order for you to even be seen a lot of the times. Yeah. Which is crazy. Yeah. It's crazy. Your CV needs to be so specifically like written that's for each individual job post, or else if the company's using AI, they're probably not going to see it. I also want to touch on, I guess you mentioned about the commercializing within healthcare. You kind of touched on an example before we started recording, isn't that the way? Which I found really interesting, because like we were saying before we started recording, it's almost if something doesn't directly affect you as a person, human nature is that you're probably never going to think about it. So you touched on the fact that a lot of these key decision makers in these executive jobs are men. So there's going to be so many situations or things within healthcare that are to do with women that men are never going to think, oh, should we invest in this company whose main aim is to, I guess, create a vaccine for cervical cancer or something like that. That's never going to be a thought process. And you kind of touched on, was it condoms, wasn't it? Yeah. So no, I was just so this idea that you don't want to come across as salesy in healthcare, because it's bad and people get very funny about it. There is an element though of sales and having to be strategic and commercially minded, in particularly when you're growing a business or you're scaling something up. That's something you have to be congruent with and genuine about, because people can sense that straight away, and they won't invest in you, or they won't want to form those relationships because it's so clear. But if you genuinely are passionate about something, more likely to get that. And I guess what I was sort of lamenting on with you is this idea that when you have a startup, say, looking at condoms, the way that we've done condoms, or endometriosis even, like there's not a lot on that in the space, probably a female entrepreneur trying to raise money. A lot of the time it's males in those key decision, signing those checkbooks on to whether they get funding or not. And it's really interesting to learn, because 15%, I think there's only 15% of women in VCs versus, the rest, which are men. And just through no fault of their own, they're probably going to sit there and not really have the expertise, understanding, or think, menstrual pain is really intense for women. Like we should, look
invest
into what
in this.
We can do. Yeah, exactly.
Yeah, and of course they do their due diligence and everything, but also it's just part of human nature to more strongly, I guess, empathize with something that they can relate to. And I think there's also this research about how male investors tend to ask more challenging questions about the risks to female entrepreneurs who are traditionally going into femtech, for example, versus, successful, how successful is my investment going to be to male entrepreneurs? And I use the idea of condoms because I think it's really interesting, because it hasn't been reinvented or redone for a very long time. And there actually is is a company looking at this, but like primary consumers in certain age brackets are females. So all of our marketing should actually theoretically be targeted towards women to buy these condoms, except they're not. They're targeted towards those more masculine things for men.
Yeah.
And even the way that we produce condoms, it could be so much more environmentally sustainable. A lot of the processes that we use causes a lot of excess water and energy that we don't need to be spending. Even the materials don't degrade properly in the environment. So we really could be looking at how we could do this better. But yeah, I think it's about jumping across that gap and being commercially minded. So if you do have a problem that you're really passionate about and you want to solve in business, you need to be aware of the mental space of some of these key decision makers and approach it accordingly in a way that they'll understand, and they'll want to help, and they'll want to invest, and they'll want to empathize with you, because at the end of the day, men don't have uteruses. No. I mean cis, traditional men, I don't want to get caught up in the terminology here, but like they don't have uteruses, so they can't
can never really understand
what women go through. And I think I was reading the other day, 1 in 9 women in Australia suffer from endometriosis, for example.
Did not know that.
And so it's quite a common thing, and 50% of the population, if you think about it, menstruate. But it's something that there's not a lot happening in tech right now, and I think there's a real hesitancy to invest in this space because it's so new. We've only been including women in clinical trials since the 90s.
Yeah.
And I actually have a statistic on that that I wanted to share with you.
Talk to me.
Because it's quite fascinating. So I'm just waiting for my phone to load.
I'm excited for this statistics. I'm all about them.
Yeah, it's going to be a big build-up now. You're like, oh, that's actually not that good.
It's not that interesting.
So there was this question that was raised that I read about, this idea that why does a symptom affecting 19% of men get 5 times more funding than a symptom affecting 90% of women?
Okay.
So, that's to do with erectile dysfunction, 19% of men.
What?
And 90% of women, the statistics referring to menstrual-related issues, so like pain and all those types of things. And we're only just getting,
Did not know that.
Yeah, so we're only just getting Victorian government to supply free pads and tampons in public schools. Most recently, the budget got released. They've allocated $59 million to endometriosis under the Women's Health Strategy 2020 to 2030. But if you figure out over 10 years, that's $5.9 million per year, and then you divide that by the number of women who suffer from endo, that's like $4.08 for their treatment per year.
Not that much.
No, it's not that much to help them.
Actually, it's not anything at all. Literally.
Yeah, so it sounds amazing and it sounds really good, but I just think there are so many gaps, particularly in the healthcare space, and unfortunately there is this, not just women, also, what about people with disability? What's happening for them and their sexuality? How are they exploring that, and what devices are available to assist them with that, or even trans people and binding, they could really hurt themselves if they do it the wrong way. Where's the information on that? Where's the investment in these populations of people that are very much part of our modern day? And particularly in health as well. And I think that's what's kind of missing at the moment. And I think you have to be commercially minded to realize this.
Because again, like we said, if it doesn't really affect, I would never think that on a day to day. And again, it goes to the fact that, if it doesn't affect you, it really isn't at the forefront of your mind, which is a horrible thing. But again, human nature is that's just the way we are. But like you said, that's why it's so important to, I guess, commercialize healthcare to a point where this does become at the forefront of many venture capitalist minds, many C-suite executive minds, because that's the only way that these things will get pushed forward. And
I'm definitely not anti-men or anything like that.
No,
it's
not
just
at all.
More,
it didn't come across that way, don't worry.
No, it's just more we have to work together, and we have to understand that men are just as much part of these conversations as women are as well. And so if we can formulate pitches or arguments or present statistics that are relevant to help understand that, you're never going to know what someone else is going through unless you're exposed to it
Yeah.
It's just that basic principle.
What are your hopes for the future of healthcare?
This is such a big question.
I feel like we've covered loads that could be your hope for the future in this podcast. But have you got something specific that you'd like to see moving forward?
See, I feel like I don't really have all the answers. I still have so much more to learn. I just have to
take a sip.
I get very overexcited when I'm talking about this, so it all just gets a bit dry.
I'm here for it.
Definitely think that we need... Okay, so first of all, aged care. There's definitely more we could be doing in the aged care space to support our elderly, but also to support the staff in the aged care space. I think there should be more incentives around wanting to motivate people to work in aged care. I do think that they need to be paid a lot more than what they're currently paid. And also mental health is just basically... We could be doing better. We could be sending in, psychologists to help support the staff in managing what they're doing. They deal with everything, Imagine having to look after a whole home of people, a whole bunch of strangers, where you walk into a supermarket and go, hey, you, come home and let's all live together. Now let's deal with all the, behavioural and
issues,
health problems that you've got going on. And put that all together. That's hard. That's challenging, and they are trained. But I certainly think with the current climate and health, it's been really challenging. Done. Yeah, and could be more done. I think it definitely shouldn't be a punitive system where we make them an example. This may be controversial, but the inquiry they did into aged care, it was very much sort of down on the staff that work in aged care, and I just don't. And yes, there is maybe a certain level of elderly abuse that happens, but I think that was really sensationalized by the media a lot. And I think that there are a lot of good people trying to just do their best, and they do need more support.
Yeah.
And I think more young people should be engaged and involved and aware of that, because these are people that have lived their lives, paid their taxes, built our society. Yes, they've probably made mistakes in climate and all that sort of stuff, but
Haven't we all?
Yeah, we've all done stuff, but they do deserve more and better healthcare and better access to healthcare. And I think that's what's kind of really lacking. And we're kind of getting there with telehealth and the MBS items. But again, restrictions came back in most recently in the last couple of months, which meant that a lot of the GPs that were seeing residents in their homes over telehealth, they could no longer do that anymore.
Oh,
yeah,
I
because
didn't know that.
Yeah, because first of all, it's really hard to, if you work in a general GP practice where you sit down and you see patients, there are some that decide, okay, I'm going to go between this hour and this hour to see these patients. It's a lot for them. They have to get in their car, drive there, see them, and then get back in their car, drive back. It's just not really worth it for them. So telehealth was a way that elderly people could get access to these GPs without them having to have too much of a disruption to their day, so they could still seeing their regular patients as well. So some of these items, particularly in regional and remote areas, means that people can't access that anymore. So I'm really hoping, and then I think there's a whole other area in women's health, trans people, disability, more funding needs to go into the research to help. There's some amazing commercial products that are trying to go onto market that just don't have the investment yet, because I think people are a little bit tentative about investing in these products because it's a new market. But I think if you really look at it, it's not a new market. They're very much a part of our society for ages. Bumpin's an amazing one. She's come up with a vibrator for people with a disability to be able to, self-pleasure. And so that helps them get their own sense of identity and sense of independence where they may not necessarily have independence in other areas of their life. People like that who are really passionate about that need funding to help their medical devices move forward. Unimon Technologies, they're trying to develop a more environmentally sustainable condom, and it's a non-latex condom using biopolymers, which is so amazing, and 3D printing. And their whole thing is that their whole manufacturing process is done in a shipping container that could literally be transported and dropped in the middle of anywhere. So you could basically move it and drop it in the middle of an indigenous community.
That's insane.
Yeah, so they can have access to protection.
Protection, yeah.
And endometriosis as well. I touched on, there's so much more that we could be doing for women in this space and the pain that they go through, like women who pass out or vomit or can't go about their day-to-day lives because there's basically they don't even know. It's 7 years before they're diagnosed with endometriosis, and then the intervention is surgery. Like we could be doing better with that. So I guess I have hopes in all of these different areas that more is being done off the top of my head. Yeah.
And then just to finish off, could you give us 3 tips for someone who, I guess, is entering the healthcare industry and may want to go down the non-beaten track, kind of similar to what you've done? Do you have any tips for someone like that?
Yeah. I think thinking outside the box. I always hate when people say that because I'm like, what does that even mean? But I think a lot of where I've found the most joy in what I've done is where I've seen a problem and then tried to come up with a super creative solution to solve that problem. So it could be something as simple as when during the pandemic, a lot of the staff were anxious about not receiving their PPE on time. So we were like, okay, let's do what we can. Let's try and make face shields and we'll drop them off at midnight so that they can have them for the next day. They can feel happy and comfortable. And we made, hundreds of face shields, just using a at-home laminator and an elastic or whatever. So even something as small scale, as simple as that really had a lot of impact on the staff and made them feel good. And so I guess, being creative, thinking about ways of solving problems in that way. I think being open, staying open, not
Seems
having
to be one of the main ones. Being open-minded.
Yes.
Yeah.
Staying open, particularly to opportunities. Like I never thought I would find myself on a podcast with you. I never thought I'd find myself on a podcast with Listener, but someone, you and, amazing Kim Norman who worked at Listener, she saw something in me and was like, do you think you'd ever want to do this? And instead of saying, oh God, I'm so nervous, like I don't know if I can.
Yes, let's see what happens.
Yeah, let's see what happens. Yeah, let's see what goes on.
Literally.
Yeah, so saying yes, but not to the point where you're,
ignoring yourself too much.
Exactly, because that's something I've also learned, to be more aware of my boundaries around my limitations of my physical and cognitive energies. It's I'm more aware of that now. And I think also something that is important is you're the product of the 5 people that you surround yourself with.
Ooh, I like that.
Yeah, so that's something I think about a lot because I try and surround myself with other women and other amazing mentors and people who are just as passionate about healthcare, just as driven as I try to be, because I model myself off of their, what they're doing.
Exactly.
So one of my amazing friends, for example, she came from Lebanon in the midst of war, got a scholarship, studied medicine. Now she's over in the US at Penn, at Duke University Hospital, training in cardiology.
Nice.
And she just, overcame all these barriers. And now she's this amazing researcher and is trained to be a surgeon. Another one of my friends, it's just like, I don't know why I thought of that specific example, but
that's good. That's a good example.
But it's good because it just keeps you focused, and you think like, if people like that can do that, then I can do what I'm doing, and also everyone's your mentor. So that's another thing that I like to live by. Always learning, always asking people a million questions, being genuinely interested in how they got to where they got to. That's something that I've always tried to not tried, but just come naturally to understand that. I think that works well. And also, like I mentioned before, if you tell someone that you're passionate about something or you want to do something, they're quite receptive and they're more likely to help you and they're most willing to help you too. So yeah, I don't know if that's 3, but maybe it's more than that.
That might be 4.
Good.
Thank you very much. That was an amazing podcast. If you're still listening up until this point, I'm sure you're very motivated and inspired by everything Zoe has said, all the work that she's done with Docs and Call. She's an editor with a journal. She has her own podcast as well. All these things that, like she said yes to and been open to the opportunities of doing something completely left field and outside of the realm of what she thought she was going to be doing with her life, is something to really, really admire. And again, Zoe, thank you very much for sitting down with us today, and I hope you've had a good time chatting.
It's been fantastic. Thank you so much for having me. Appreciate it.
You're welcome.